I'm going to talk a little bit about the current trends in arthroplasty, kind of what we see out there, what's maybe on the horizon, and then kind of coming to the conclusion that everything that we've done the last 10 to 12 years, which has been an explosion in advancement in technology, is all merging. Everything that we did 10, 15 years ago is actually setting the road for what we're going to be going in the future. And why is it the knee that we're very concentrated on? Look at the graph. This is the number of joint replacements we're going to do, relatively hip versus knee. And it's also the procedure that we don't seem to get the satisfaction rates that we seek, that we do usually get with total hips. My disclosures. So the surgical technologies that we've seen, we've maybe dabbled in, they're still out there. Includes the patient-specific, the navigation, the custom implants, the smart tools, the explosion of robotics, and then also with patients, the wearables, artificial intelligence, and machine learning. I think many of us may have dabbled in this. This was an incredible idea that we saw. It was the ability to go ahead and get a CT or an MRI, debatable which one was better, but you would get a custom block placed on the patient's knees. Obviously, the ones that had the most osteophytes or ridges seem to have fit these custom implants even better. And the idea was to make a personalized surgical plan where the surgeon goes through this, designs it, how he wants to cut, what he wants as bony resections, and then in the OR, you're going to get these blocks. These blocks were then either complete set of every block you needed, or it worked in conjunction with your implant system after you've drilled the holes. What did we learn about this? Probably not much different between conventional instrumentation. There really wasn't a study that showed a significant clinical or functional outcome that was better with PSI versus conventional. It was really working with just the bony aspects of the knee replacement. And it did not allow any gap balancing or soft tissue. This was still at the surgeon's discretion intraoperatively. There's maybe 1 or 2 studies that actually showed maybe the alignment was even worse. But we did learn. We learned how to use computers, we learned how to use printing mechanisms, we learned how to take CTs and MRIs and create designs. So it did give us a different aspect or a different way of thinking of this outside of using conventional instruments. The Otis Med came out, and this was again in the same design and kind of pushed with the idea of maybe we should be doing this in a kinematic design. So we started seeing some differences of opinion on how to do a knee with PSI. The next, what we saw was some custom implants. And this really helped us improve technology in the sense that now we have 3D printing. We could actually make the implant customizable to the patient's anatomy. Again, a CT or an MRI is used. And the idea was, if some standard off-the-shelf implants maybe reduce overhang, maybe decrease underhang, it may control your tibial resection so you don't have an overlaxity if you take too much bone, and the ability to maybe restore the curvature or the radius of curvature of the condyles using these technologies. And again, studies out there, some would support them, very few have long-term clinical outcomes. And again, the surgical balancing is taken in the hands of the surgeon at the time of surgery. One study that did show is, use these, but then you couldn't necessarily predict how that knee was going to fit. About 46% of the time, you had recuts in these. So before we talked everything about basing everything on bony anatomy, PSI, custom implants, and then we started seeing some sensor technology. A couple companies out there, I think there was one major VersaSense that most of us saw, and it was pretty much implant agnostic. You could get that for your tibial base plate, but it was a wireless, you would put it in the knee, and now, not only are you looking at maybe your bone cuts, but you're seeing how the pressure is in the knee. And then this would allow you to then to maybe freehand adjust a bone cut. You could do a surgical or a ligamentous release, depending on what you received on the sensor data. Real question was, what was a good knee? We weren't sure. How much pressure should you have? I think some of the big takeaways was the medial side should be definitely tighter than the lateral side. If the lateral side was tighter than the medial side, you could have some issues. Which points would you take? Here you can see you took a 10, 45, and 90. Should you take a mid-flexion point? And then also this is very surgical dependent. I mean, if you've had a heavy leg and you're trying to take this through the range of motion, the pressures could be off a little bit as well. But this technology worked in the hands of some people, but overall, we didn't see necessarily statistical outcome of functional and clinical results that were better than what we were doing before. But again, it's getting us to think as we move through this technology phase. Accelerometer technology, kind of a navigation, but an intraoperative navigation in the sense that here you started seeing the ability to design the knee maybe in different ways, maybe making it more individualized. Do you want to cut the femur in a little varus, or do you want to cut the tibia in a little bit of varus? But most importantly, you can then verify those cuts. Some of the other technologies, PSI, you would make your cuts, but you could never necessarily verify that's exactly what you did. With accelerometer technology on the femur and the tibia, you can actually change the alignment, flex the femur, change the slope of the tibia, and then you can also verify it. Really no studies, again, showing complete clinical outcomes that are better than over conventional technique, but you can see we're moving in the direction of thinking of different ways of doing knees, different ways of reproducing it, and different ways of validating it. And as we all see, inundated here in the last few years, is robotic technology. And robotics has come out with really three platforms. You have the passive, semi-autonomous, and the autonomous. And then within those systems, you can use CT, MRI, advanced imaging. You can use more or less freehand or imageless or standard x-rays. And you can see some of the newer robots coming out are moving away from kind of the CT or MRI base, allowing you to do this imageless intraoperatively. From the three categories, the initial ones were the autonomous, where the surgeon made the plan, fixed the knee to the robot, and the robot did all the work. It did all the cutting. And now we've moved more towards the semi-autonomous, where the surgeon's performing both the planning as well as manipulating the saw in their hands. Now, of all the technologies we talked about, this is the one that will not only incorporate the bony resections to hopefully improve alignment, but now you can design the knee looking at the ligaments. You can adjust the ligaments. You can choose many points. Some systems only limiting a 0 to 90 degree choice, others allowing a full arc of motion with pressure sensors, and others allowing you to pick 0, 45, 60, 90, or other points. Some of these systems can not only do the uni and the total, and then also have a total hip application. But essentially, we don't have a ton of long-term studies to see. Studies out there showing is this a benefit over conventional? I think they're equivocal. The only really long-term ones were the autonomous, and those long-term studies haven't shown much of a difference in the survivorship. But with robotics, you can now try to figure out how you want to do this knee. You are no longer just a measured resection. You are no longer just a kinematic. You can do kinematic. You can do inverse kinematic. You can do restrictive kinematic. And then essentially, you can do gap balancing. But I think what ends up happening with robotics is you just create what we call a personalized or a functional approach. You probably dip into every one of the things we're going to talk about today and every technique that's out there. And you become almost personalizing each individual knee for each individual patient. Outside of technology that we have in the OR, we're increasing our ability to use wearables. If you look around, every one of our young patients has a Fitbit, has an Oura Ring. This is a trend in everything we do, monitoring. Not only is it good for the patient, but it may give us some benefit in the clinic. We might be able to figure out which patients may not be performing well. We might be able to identify the slow progressors, intervene earlier, maybe reduce outliers. If a patient calls you and he's got tremendous amount of pain, you can look at his wearable device and go, well, you just walked 18,000 feet yesterday. That's why you're hurting. Versus your knee-jerk reflection, which would be, come on in, you may have an infection, let me take a look at it. The wearables is a great way to communicate. It gives patients something, a baseline to achieve. You know, the problem, like on this one where you're wearing it around your thigh and your ankle is the compliancy. I mean, I don't think any patient's gonna walk around all day with these, but you can identify. The next generation is gonna be the smart implant technology, either implanted in the base plates and the stems or in the poly. Obviously, compliancy is 100%. And these sensors have the ability to really measure any kind of a physical property that we want them to. Temperature, pressure, distance, speed, torque, acceleration, and it'll send it to an electronic processor, and then we can go through and figure out what to do with that data. What's on the future? Well, maybe we detect if there's loosening. Maybe if the temperature goes up within the implant, we can say, hey, there's an infection occurring. But we can also more or less see how our patients are doing. You can essentially then create these graphs here of, let's say on the bottom here is walking speed. You can see almost like a growth chart for an infant or a child, where you can actually see where your patient stands on there, where he should or she stand compared to her age. You can then cross-reference into possibly BMI or activity levels, and you can create a graph of what percentile they are. This can actually warn you as a surgeon if a patient's dropping off, and then you can intervene earlier than later, maybe improving outcomes if you can improve in an earlier part of this patient's recovery process. The other issues are, can you create an XYZ of the way the patient's walking? So now you can see if a patient's not doing well, is there a possibility to tell on their walking speed, their gait velocity, is there some muscle group they're not activating? And you can almost then maybe create a personalized physical therapy approach for this patient. But this is what we're doing, and this is where machine learning and artificial intelligence is going to play, is it's going to be able to predict. Remember that movie Minority Report where they would look at your brain before you created a crime? You now might be able to pick up on these patients before they have bad outcomes and intervene at an earlier time. Thank you.